Hi, everyone. Welcome to this program on improving the diagnosis and management of progressive pulmonary fibrosis with a focus on SSc-ILD and idiopathic pulmonary fibrosis. My name is Elizabeth Folkman, and I'm an associate professor in the Division of Rheumatology at UCLA, and I'm delighted to be doing this webinar with Dr. Scott Matson.
Thanks, Dr. Volkman. I'm Scott Matson. I'm a pulmonologist and assistant professor in the Division of Pulmonary and Critical Care at the University of Kansas.
Thanks for being here today. We have three main learning objectives today. The first is to differentiate certain diseases with a progressive pulmonary fibrosis grouping, such as systemic sclerosis-related interstitial lung disease, or SSc-ILD, and idiopathic pulmonary fibrosis, or IPF. Second, we'll identify best practices in the diagnosis and routine assessment of patients with PPF, IPF, and SSc-ILD in accordance with current guidelines via real-world patient case scenarios. Our last objective is to recognize ongoing developments in clinical research and treatment guidelines that may impact the multidisciplinary management of these diseases going forward. So to meet these objectives, we have the following agenda. We'll differentiate pulmonary diseases that can manifest as progressive fibrosis by discussing the first case, SSc-ILD, and then the second case is IPF. And throughout the way, we're going to work on highlighting the importance of multidisciplinary care. There's a spectrum of fibrosing interstitial lung diseases, and a recent study that was published in 2021 demonstrated the prevalence of various fibrosing ILDs in both Europe and the United States. This study found that sarcoidosis had the highest prevalence, followed by idiopathic pulmonary fibrosis, and then SSc-ILD. The figure on the right demonstrates the overall prevalence of ILD with that green circle. And then what you can see in the blue circles is the prevalence of individual fibrosing ILDs with a progressive phenotype within these different ILDs. For this talk, we're focused again on SSc-ILD, which is an autoimmune ILD, as well as idiopathic pulmonary fibrosis. In 2022, the American Thoracic Society collaborated with a number of respiratory societies throughout the world to develop a definition for progressive pulmonary fibrosis, or PPF. And this was largely based on expert opinion. The definition is in a patient with ILD of known or unknown etiology other than idiopathic pulmonary fibrosis who has radiological evidence of pulmonary fibrosis. PPF is defined as at least two of the following three criteria occurring within the past year with no alternative explanation. The first is worsening respiratory symptoms. The second is a physiological decline, which could either be a decline in the FVC greater than or equal to 5%, or a decline in the DLCO corrected for hemoglobin greater than or equal to 10%. Third is radiological evidence of disease progression, defined as one or more of the following. Fibrosing ILDs can have common diagnoses, and we typically categorize patients as either having idiopathic or non-idiopathic interstitial lung disease. So IPF is a common example of an idiopathic fibrosing ILD, whereas connective tissue disease-related ILD is a non-idiopathic form, and this form includes patients with SSc-ILD. The prevalence of ILD can vary across the different connective tissue diseases. So in this graph here, you can see the prevalence of ILD across different autoimmune rheumatic diseases. You'll notice, however, that there is a range of prevalence, and this is because the true prevalence is not known. Many of the studies that ascertain prevalence of ILD use different methodology for screening or diagnosing ILD. Some studies may use a high-resolution chest CT, which would be the most sensitive way to detect ILD, but others could use pulmonary function testing or chest X-ray, which can be insensitive for detecting ILD, particularly early interstitial lung disease. So again, this is why for diseases such as lupus, you can see a wide range of prevalence. What's probably more important, though, is to understand the prevalence of progressive pulmonary fibrosis in these patients. And you can see that little is known about lupus, Sjogren's, mixed connective tissue disease, and myositis, But at least for systemic sclerosis and rheumatoid arthritis, the majority of patients who have ILD will have a progressive phenotype. As a physician, you need to be aware of interstitial lung disease symptoms. The most obvious symptom would be dyspnea, and this can be related to other causes, but it can also reflect disease severity of ILD. Cough is another common symptom. Usually this is a dry cough, as productive cough is unusual for most ILDs, but you can see a productive cough, particularly when a patient has reflux disease, as many of these patients do. Chest pain is more common in connective tissue disease related ILD, and this can have cardiac etiologies in addition to respiratory etiologies. And then finally, these patients can have a myriad of extrapulmonary symptoms that could suggest a CTD, such as arthritis, photosensitivity, Raynaud phenomenon, dry eyes, and dry mouth. It's important for all patients with interstitial lung disease to undergo a comprehensive evaluation, and this should definitely include a CT of their chest as well as pulmonary function testing. Serologies can be critical in diagnosing patients with connective tissue disease-related ILD. And in select cases, patients may need to undergo bronchoscopy with BAL or even lung biopsy to help with the diagnosis. All patients with ILD should undergo a multidisciplinary discussion to determine the diagnosis. And at that point, patients can either be monitored closely or they can be started on treatment. And when they're monitored closely, this will allow you to determine whether the patient meets criteria for progressive pulmonary fibrosis. I want to speak a little bit about radiology for ILD, and I would invite Dr. Mattson to tell us a little bit more about radiological features of idiopathic pulmonary fibrosis.
Thanks, Dr. Volkman. As Dr. Volkman mentioned on the previous slide, high-resolution CT scan interpretation is an important part of the diagnostic consideration in the evaluation of interstitial fibrosing pneumonia. And idiopathic pulmonary fibrosis is defined by the radiologic pattern of usual interstitial pneumonia, or the UIP pattern. The presence of UIP pattern is required for a diagnosis of idiopathic pulmonary fibrosis, and there's a spectrum of UIP pattern which has 4 different categories. Here we've shown you 3 of the predominant UIP patterns based on the presence of radiographic features of fibrosis. From the left to the right, you could see a UIP pattern, a probable UIP pattern, and then an indeterminate UIP pattern, which has to do with the presence of those 3 features of radiographic fibrosis, namely reticulation, traction bronchiectasis, and honeycombing. Many conditions can present with the UIP pattern, such as scleroderma or rheumatoid arthritis-associated interstitial lung disease. However, for a diagnosis of IPF, UIP pattern is required to make this diagnosis. And this has to do with the underlying comparison to the histologic pattern that's seen on a biopsy based on the spectrum of this UIP pattern seen here on these slides. Next, we'd like to look at comparative radiology that's seen within patients who have scleroderma-associated interstitial lung disease. And scleroderma, like many autoimmune diseases, can manifest in essentially any of the known underlying ILD patterns. And so as we saw on the last slide, UIP pattern interstitial lung disease is required for a diagnosis of IPF. However, for a patient with scleroderma, essentially any of the known ILD patterns have been seen in patients with scleroderma. In this case, what we focus on for patients with systemic autoimmune disease is what are the features and the extent of fibrosis seen on the CT scan, and what does that mean for the patient's individual prognosis or potential response to treatment. In this case, what we can see is a varying degree of different radiologic patterns. And what's important to know about patients with scleroderma is that in this case, fibrosing interstitial pneumonia is again defined by the presence of reticulation, bronchiectasis, and the presence of honeycombing. However, because of the diversity of ILD patterns seen in these patients, they often also have a preponderance of ground glass opacities, which can manifest in airspace consolidation and can be associated with other predominant patterns of interstitial lung disease, such as the nonspecific interstitial pneumonia or a patient with a cystic predominant pattern known as the lymphocytic interstitial pneumonia.
Thank you, Dr. Mattson. That was excellent. So let's now move into our first patient case. We've learned some lessons about radiology and monitoring for progression of ILD. Our first case is a 46-year-old white female presenting for evaluation of SSc to our rheumatology clinic in 2016. But her history dates back to 10 years prior, when in 2006 she developed Raynaud phenomenon. And then in 2013, she developed puffy hands and was found to have a positive ANA. At that time, she saw a community rheumatologist who diagnosed her with undifferentiated connective tissue disease. A year later, she went back to that community rheumatologist and further lab testing was done, and she was found to have a positive SCL70 antibody. A CT of her chest was also obtained, which demonstrated ILD, but no treatment was offered her at that time. 2 years later, she developed shortness of breath. So this patient came to our center in 2016. And at that time, she had the following symptoms: dyspnea on exertion, dry cough, heartburn, as well as joint pain in her hands and feet. On physical exam, she was found to have bibasilar crackles. She had some perioral furrowing, and she had notable sclerodactyly with a skin score of 2. So this indicates that she had thickening of the skin of her fingers bilaterally. And here's a picture of a patient who has sclerodactyly. So you can see there's also a shininess of the skin, which can happen in scleroderma as well. In terms of the prevalence of ILD, it is highly prevalent in patients with systemic sclerosis. 52% of patients with SSc in North America have ILD. It's also one of the leading causes of death in systemic sclerosis. And when patients have ILD, it significantly affects their quality of life and functional capacity. Progression of ILD to PPF is common, but it's highly variable within an individual patient. One study found that approximately 1/3 of patients experience progression at 1 year, while 2/3 experience progression over 5 years. In 2013, the American College of Rheumatology created guidelines to address screening for systemic autoimmune rheumatic diseases, which they abbreviate as SARDs. They recommended conditionally screening with PFTs, screening with HRCT, and finally screening with HRCT of the chest and PFTs over PFTs alone. The guidelines also discuss risk stratifying CTD for screening based on risk factors. So for systemic sclerosis, which is the focus of this case, there are certain risk factors that predict a greater likelihood of a patient having ILD. These include the anti-SCL70 antibody, an ANA antibody if there's a nucleolar pattern, diffuse cutaneous subtype, male sex, African American race, early disease, so within the first 5 to 7 years from the onset of the first non-Raynaud symptom, as well as elevated acute phase reactants. So let's get back to our case. This patient underwent serological testing, and I recommend doing this for all patients, particularly these patients who have a positive SCL70 antibody, because there can be false positive SCL70 antibodies. So it's important to confirm that this test is truly positive. But indeed, this patient did have a positive SCL70 antibody. She also was negative for anti-centromere, and she had a positive ANA with 2 patterns, homogeneous and nucleolar. We obtained pulmonary function testing on this patient, and our FVC was 72% predicted, and our DLCO was 57% predicted, indicating restrictive physiology. I went back and looked at her PFTs that were done prior to a presentation, and you can see that her FVC, and this is represented in milliliters here, had declined over this time period. Her DLCO was a little bit more variable. There was a initial decline and then it came up a little bit, but I think this reflects the variation of DLCO testing, and that in an individual patient, this can vary even on a daily basis. This patient also had CT imaging, and I wasn't able to get her CT imaging from her initial diagnosis, but this was the scan that we obtained in 2016. And you can see circled here in red are ground glass opacities. This is this gray looking matter on the lungs where you can still see blood vessels underneath this area. This patient also had traction bronchiectasis, which is indicated by, again, a red arrow, and this is the elongation of airways that's related to having fibrosis. So let's think about how we can treat this patient. And in 2024, the American Thoracic Society developed guidelines to recommend treatment for SSc-ILD. These guidelines strongly recommended mycophenolate and conditionally recommended cyclophosphamide, rituximab, tocilizumab, nintedanib, as well as the combination of nintedanib plus mycophenolate. And further research was recommended for understanding whether pirfenidone or the combination of pirfenidone plus mycophenolate would be helpful for the treatment of SSc-ILD. In terms of nintedanib, this was the first approved treatment for SSc-ILD in September of 2019. There's been a number of results of recent trials that have showed similar benefit on forced vital capacity over 52 weeks in SSc-ILD, regardless of baseline percent predicted or the extent of fibrosis. In addition, in a post-hoc analysis of the census trial looking at patients with limited skin disease, there was a 34% reduction in the rate of FVC decline over 52 weeks in patients treated with nintedanib. We also did a post-hoc analysis looking at the risk of malnutrition in patients on nintedanib, because this can be a concern as diarrhea and GI adverse events are common with nintedanib. There was a slightly higher risk of malnutrition in patients treated with nintedanib over placebo, which highlights the need to manage gastrointestinal disease in these patients closely and work with a gastroenterologist and possibly a nutritionist. In terms of patients who had risk factors for rapid decline, and these were patients with early disease, elevated inflammatory markers, and high skin score, there was again a reduced rate of FVC decline in the patients treated with nintedanib compared with placebo. There was no significant difference in FVC benefit in patients with SSc-ILD with or without cough or dyspnea at baseline. And this was also an interesting post-hoc analysis where we demonstrated that even patients who had no cough or dyspnea at baseline, if they were randomized to placebo, they were likely to still experience a decline in their FVC. So what I took away from this is that you can't rely on your assessment of symptoms alone to decide whether and when to treat a patient. In addition, a final study demonstrated reduced worsening of dyspnea, fatigue, and cough in patients treated with nintedanib versus placebo. And this was done in a study of patients with progressive pulmonary fibrosis and included some patients with SSc-ILD, but it included other different types of ILD as well. Getting back to our case, we started this patient, as this was in 2016, on treatment with mycophenolate. Mycophenolate has been demonstrated to improve lung function, radiological fibrosis, as well as symptoms of shortness of breath and cough in patients with SSc-ILD. In addition, we referred her to pulmonary rehab. A year later, the patient transitioned to rituximab. She had developed seronegative rheumatoid arthritis, and it was very much impacting her ability to ambulate and move throughout her life and daily activities. And we use rituximab because there's evidence that this can improve lung function in patients with connective tissue disease-related ILD, including SSc-ILD, and it's also FDA approved for the treatment of rheumatoid arthritis. Looking at our pulmonary function test trends, and again, I started seeing this patient in 2016, but you can see over this time period, her FVC was steadily but slowly declining. And her DLCL followed a similar trend. And I will mention that around 2020, when the pandemic hit, this patient decided to go off of rituximab because she was concerned about getting COVID pneumonia. As I mentioned, the patient decided to stop rituximab in 2020 due to a concern about COVID-19 infection. Unfortunately, her dyspnea worsened, and she had to initiate supplemental oxygen in 2022. In addition, when she stopped rituximab, her arthritis also worsened, and she was started on low-dose prednisone, which can be disease-modifying for patients with rheumatoid arthritis. In addition, she transitioned to seeing a new pulmonologist. So how we monitor for progression in these patients is largely based on the guidelines that I previously mentioned on PPF. But in the ACR guidelines, they recommended the following conditionally: monitoring with PFTs, monitoring with HRCT of the chest, monitoring with PFTs and HRCT of the chest over PFTs alone, as well as monitoring with ambulatory desaturation testing. In terms of proposed intervals for assessments, we typically obtain PFTs every 3 to 6 months in our patients, at least for the first year, and it could be every 3 to 6 months for RA, Sjogren's disease, or mixed connective tissue disease, and less frequently when stable. In the guidelines, they recommended HRCT as needed, and for ambulatory desaturation monitoring every 3 to 12 months. But I will tell you that this can be adapted depending on the individual patient. If you have a patient who's progressing very quickly in terms of their ILD, you definitely won't want to wait a whole year to get PFTs. In fact, it's quite helpful to have multiple PFT measurements over the course of a year so you can establish good trends. But again, just to review, here are the ATS treatment recommendations for SSc-ILD. It's important to note that this is not an algorithm, so the committee was not recommending starting with mycophenolate first and then moving to these other options. There was not enough data to establish which treatment should be used as first line and which is second line, largely because most of the trials that have been done in SSc-ILD have mainly looked at first line therapy. So to follow up on our case, in 2022, the patient agreed to resume mycophenolate in combination with nintedanib. And a year later, she noticed that her symptoms started to improve and she was requiring less oxygen. She was also exercising more. In 2024, her pulmonary function tests were stable, but you can see on her CT that she's had some interval progression of her ILD. You can see there's been progression of the degree of traction bronchiectasis as well as the degree of reticulation. I feel fortunate that there are a number of drugs in late phase development for SSc-ILD, and here's a list of some of them that are being investigated not only for SSc-ILD, but also for connective tissue disease-related ILD, as well as more broadly for progressive pulmonary fibrosis. And this list is expanding every day. I want to reflect on some of the important parts of this case. The first is that, as we saw, the presence of the SCL70 antibody is associated with progressive pulmonary fibrosis. If I had seen this patient initially in 2014, I would have started her on treatment then and not waited until she developed symptoms, because delays in treatment can lead to irreversible lung damage. And we know that these patients with the SCL70 antibody are likely to develop progressive pulmonary fibrosis. Another important lesson on this case is that SSc-ILD continues to progress beyond this 5-year mark. So there's an old notion that ILD progression only occurs within the first 5 years of scleroderma. And this has been debunked because the older studies that demonstrated this were done during a time where there were no treatments for SSc-ILD. So most of the patients died, and what you were seeing was a survival bias. Now there's more recent studies that demonstrate that progression can occur even after a disease duration of 15 years. And in this EULAR abstract, you can see that among patients who were in the USTAR cohort, which is a large European scleroderma cohort, these different bars represent the disease duration of the patients. So the lighter bars represent shorter disease duration, and the dark navy bars recommend patients with longer disease duration beyond 15 years. And then the authors looked at FVC decline greater than 10%, or a composite decline that included an FVC decline combined with a DLCO decline. And they looked at this at 1 and 2 years. And what's notable about this is even these patients with a disease duration of more than 15 years were having declines in these pulmonary function test parameters. So what you need to understand from this research is that you can never stop monitoring for progression of ILD in a patient with systemic sclerosis.
This is a 66-year-old white male who presented for evaluation of worsening shortness of breath. His clinical history goes as such. In 2021, he developed a dry cough. In 2022, then, he noticed an exertional shortness of breath, which was initially most notable when climbing stairs, but then progressed to the point where he was short of breath when walking at a fast pace, even on flat ground. At that time, he saw his primary care provider, and he underwent an initial evaluation focused on potential cardiac etiologies of his shortness of breath. He had an ECG and a cardiac stress test, both of which were normal. At that time, the evaluation ceased initially, and he came back to his primary care provider in 2023, where he reported worsening progression of his dyspnea. He was now limited at a regular pace on flat surfaces, and at that point, his primary care physician ordered a chest x-ray and placed a referral to see us for a pulmonary physician evaluation. At the time of his presentation to our clinic, we noted the symptoms that I just mentioned to you, in addition to a history of worsening fatigue. And it was notable that he had reported a decreased interest in social activities, largely because of the limitations he experienced from shortness of breath and how limited he felt around his friends and peers. On physical exam, he was noted to have bibasilar crackles on lung auscultation, and he had faint lower extremity edema, as well as digital clubbing throughout. His initial clinical evaluation also found no contributions from his environmental or social history. He had a screening serologic panel that was unremarkable. His initial pulmonary function testing revealed a restrictive deficit with a forced vital capacity of 62% predicted and a reduction in his diffusing capacity for carbon monoxide. He underwent an echocardiogram prior to evaluation that showed his pulmonary artery systolic pressure was elevated at an estimated 29 millimeters of mercury, and his right ventricular function was normal, but he had a dilated RV. Here I'll show you the imaging from the patient's referral. This is the chest x-ray that was obtained by his primary care physician prior to seeing us in pulmonary clinic. What you can see on this chest x-ray is most notably is a reduction in volumes with a lower lobe predominant interstitial infiltrate that's seen bilaterally. Here's a cross-section of his CT scan, and what you can see is two selected cross-sectional cuts from a high-resolution CT scan showing evidence of radiographic fibrosis that we outlined previously. What's notable here is evidence of bilateral reticular abnormality, traction bronchiectasis, as well as honeycombing, which would be consistent with a probable UIP pattern, ILD pattern on this high-resolution CT scan. This is a diagnostic algorithm for the suspicion of idiopathic pulmonary fibrosis put forward by the consensus group that Dr. Volkmann mentioned previously in 2022 that defined progressive pulmonary fibrosis. And in this case, what we'll highlight is that for patients suspected of having IPF, one of the first clinical decision points being made is whether or not on clinical evaluation we can identify a potential cause or a systemic disease, environmental trigger, or drug-related toxicity that explains the interstitial lung disease and fibrosing pattern that we're seeing on a CT scan. When none of those conditions are met, we move on to the chest high-resolution CT in order to determine the pattern. And as we've discussed so far, a UIP or probable UIP pattern is required for the diagnosis of idiopathic pulmonary fibrosis. And in the cases where the patient meets those criteria, it's likely that that diagnosis is idiopathic pulmonary fibrosis, and that can be supported by discussion amongst multidisciplinary team in terms of diagnostic yield for that patient. However, for those patients who have an indeterminate UIP pattern or an alternate pattern based on their HRCT interpretation, that's where this pretest question really comes into play, is what do we do as a next step to try to understand diagnostically how we can determine the best treatment for that patient and what information we can add to that patient's prognosis in terms of what they can expect and what options are available for them. Obtaining a lung biopsy, whether that's a surgical lung biopsy or a transbronchial cryobiopsy, can influence treatment based on the exclusion or inclusion of alternate diagnoses, as I mentioned previously. The discovery of a sarcoidosis as a cause of a progressive fibrosing interstitial pneumonia, the discovery of a concomitant or a mimicking lung cancer will certainly alter the treatment decisions that you make for that patient. However, in many cases, what we find is more evidence that supports IPF as a likely diagnosis. A surgical lung biopsy or a transbronchial cryo lung biopsy cannot confirm the presence of IPF, but you can exclude important mimickers in the cases where they think that's required. It's also important to note that for some patients, the best diagnostic test is the application of a treatment and assessment of treatment response. And so there are some cases that perhaps in a multidisciplinary discussion might be thought to have a more autoimmune featured interstitial lung disease, in which case perhaps surgical lung biopsy may not be an initial diagnostic test and instead, application of immune suppression and assessment of treatment response might be a reasonable first step. The other important role in making this decision is what is the patient's likelihood of tolerance of an aggressive diagnostic procedure such as surgical lung biopsy or endoscopic lung biopsy. And that's again where one of the roles of multidisciplinary discussions in the diagnostic considerations of patients undergoing this type of workup. When a patient's been diagnosed with IPF, one of the most important things to try to convey is what's the likely prognosis and natural history. And one of the things that we see from several well-done epidemiologic and observational studies is that there's a varied course for each individual patient. And this largely probably relates to the fact that IPF remains a subjective diagnosis without a gold standard diagnostic test, which means there's a pretty significant underlying heterogeneity for patients who meet this clinical diagnosis. And what this diagram outlines is what we see in a patient-by-patient basis, which is that some patients have a relatively slow and stable course and can see us in clinic for several years with only a moderate decline in lung function and only a moderate concomitant decline in their quality of life as a result of that lung function decline. While there are some patients that unfortunately come to see us and over the next year or two have a very rapid decline and a significant loss of lung function and a significant decline in their functional status. And those patients are often also accompanied by a stair-step pattern that is punctuated by acute exacerbations of their underlying lung disease. When a patient's diagnosed with idiopathic pulmonary fibrosis, there are several treatment considerations that a specialized ILD clinic would consider as a next step. Of course, in 2014, there were 2 pharmacologic agents approved by the FDA for the treatment of idiopathic pulmonary fibrosis, and those are the broad antifibrotic category of drugs that include nintedanib and pirfenidone. But there are also important non-pharmacologic treatments, including oxygen supplementation, the use of pulmonary rehabilitation, identification and treatment of important comorbidities such as pulmonary hypertension, gastroesophageal reflux, obstructive sleep apnea, and lung cancer. And then an important tenet of management for these patients is focus on symptom control and potentially collaborating with a palliative care team to help manage symptoms and sometimes end-of-life considerations. One of the important considerations that a physician and patient and family unit has to make early in this diagnosis is whether or not lung transplant referral is going to be an option for this patient based on their underlying goals of care and their ethos of decision making as they work through what the likely prognosis is, what the likely treatment would look like, and then what the lung transplant process involves, including the procedure itself and recovery. And so one of the important considerations for patients and providers who are seeing patients with idiopathic pulmonary fibrosis is the ongoing evolving discussion of when the right time is for that person in front of you to refer them for lung transplant, if that's within their goals of care. After the initial treatment and the initial application of these non-pharmacologic approaches, management of comorbidities, the role of a pulmonologist and multidisciplinary team that's following a patient with IPF is to monitor for signs of symptom and disease progression, and then to adjust the treatment strategy and the amount of providers involved in that patient's care to most address where that patient is in their current disease course. And again, throughout the course of this particular treatment progression, and disease progression, the ongoing consideration of lung transplant referral times, as well as communication with the lung transplant team based on how things have progressed for that particular patient. Going back to our patient, in April of 2023, at the initial evaluation, based on his UIP pattern, interstitial lung disease, and rest of his diagnostic workup, he was diagnosed with idiopathic pulmonary fibrosis and initiated on nintedanib, one of the antifibrotic drugs, at the starting dose of 150 milligrams twice a day. About a month after the medication was administered, the patient reported significant GI symptoms, and the dose was decreased to 100 milligrams twice per day. At the first follow-up visit to our clinic, which was 3 months after the initial visit, he comes in with repeat pulmonary function testing and for assessment of his clinical symptoms. And here we've supplied the initial pulmonary function testing from April and then the follow-up testing from July. And what you can see is that there's been a decline in both the forced vital capacity and the diffusing capacity for carbon monoxide. And this is a common scenario that I think is difficult for most pulmonary physicians treating this condition on these antifibrotic therapies to approach. which is both drugs in the antifibrotic category, nintedanib and pirfenidone, have both been shown to have a clinically significant and statistically significant improvement compared to placebo. But in both cases, universally, patients tend to decline on the average from where they started, which means when a patient comes back to see you in clinic and they have declined from where they started, what's really hard to know is how much worse that decline would have been had they been off of therapy, or how much better might that decline have been on an alternate therapeutic strategy. When the counterfactual that you're arguing against is a worse decline and the patient comes back to you with some decline, it becomes very hard to know if this drug is quote unquote working or not. And when the patient tells you that they feel a little worse and their pulmonary function testing is a little worse than when they started, that's of course what we know these drugs to do. And when their therapeutic benefit is to slow decline compared to placebo, it's difficult for a provider to know if the therapy should be changed, if the therapeutic strategy is not working, or if things would be much worse had you not initiated that initial strategy in April. And so this is a common clinical conundrum that we face in clinic. One of the questions I think many providers face is one of these drugs better than the other? We have two antifibrotic strategies, and I think it's fair to say that most providers who use these drugs regularly often choose them based on the adverse effect profile, largely because we believe the clinical benefit to be about the same. And this is a really well done post hoc analysis of the cleanup IPF study that was published in 2024, which asked in a well done post hoc analysis whether or not there was a difference in 12-month forced vital capacity outcomes between the two antifibrotic drugs in patients who were in the cleanup IPF study came in on these therapies. And what you can see is that in this post hoc analysis, there was a higher 12-month FVC for those patients on nintedanib compared to pirfenidone, but by 24 months, so at 2 years, that difference had been attenuated. And I think most importantly, for patient-centered outcomes, such as overall survival and respiratory hospitalizations, the group found no differences at all between the two therapies. And so again, I think in a patient who comes back to see you with some progression on the initial antifibrotic strategy that you chose, at least with the current level of evidence, it's hard to say that switching therapies would have a therapeutic benefit. But I think it's also fair to say that if a patient's having an adverse effect profile from one of the therapies, it's reasonable to switch between therapies in order to try to make symptoms better and quality of life better, knowing that the therapeutic benefit is likely about the same from each of these therapies. In addition to the initial pharmacologic management, this is what the care of this patient looked like in the first several months. So at the first visit, our group tends to focus on at least a discussion of the role of lung transplant to try to at least set the stage for what that kind of referral might look like, what a lung transplant evaluation might look like, and to assess whether or not that's something that the patient and family has within their pre-selected goals of care. We also commonly make a referral to a pulmonary rehab and a local pulmonary fibrosis support group for the patient. Our ILD pharmacist assists with management of side effects from the therapies and helps with dose reduction recommendations based on the side effect profile. Based on our initial discussion and then the patient's decline on pulmonary function and symptoms when they came back to see us in July, the decision was made together to refer to lung transplant to have the discussion of what a lung transplant would look like, what recovery would look like, and what would be required of the support system for the patient. We also referred the patient to our advanced lung disease palliative care team, which involves a psychologist and a palliative care physician that's in the same space as us physically and has a track record of working with us for patients with pulmonary fibrosis. Around the first part of 2024, the patient was referred to the pulmonary hypertension team based on the echocardiographic results, and a right heart cath found confirmation of the suspected elevated pulmonary artery pressure, and the patient was initiated on inhaled treprostinil therapy, which has been shown to improve 6-minute walk distances for patients with IPF-related pulmonary hypertension. After that, the patient came back to see us after discussions with the lung transplant team, and the patient and family had decided together not to pursue lung transplant based on their own goals of care. In April of 2024, unfortunately, the patient was admitted for an IPF exacerbation and hospitalized in our system for 6 days. At hospital follow-up, we arranged the patient came back to see us in clinic, and they had a marked forced vital capacity decline down to 41% predicted. And as to be expected with that kind of decline, there was worsening shortness of breath, and it had progressed to the point now where the patient was essentially short of breath with any ambulation in the home. He'd had worsening cough, and he had worsening anxiety as a result of all of these symptoms. and the O2 needs had been increased up to 6 to 8 liters at rest, even at the time of follow-up. At this time, with consultation from our ILD palliative care team, patient was also initiated on a PO narcotic therapy for air hunger and cough. As Dr. Volkman stated about SSc-ILD, we're also fortunate in the management of patients with IPF that there are several late-stage investigative trials in phase 2 and phase 3 for therapies for the treatment of idiopathic pulmonary fibrosis. A few reflections on the case that I presented to you today. Idiopathic pulmonary fibrosis, unlike systemic autoimmune diseases, pathologically only affects the lungs. But what's clear in taking care of these patients is that the disease is multi-system, and the manifestations of this condition move far beyond just a lung disease. And most notably, I think that comes down to the psychological loss of mobility, the psychological loss of quality of life that comes from this kind of condition. And what that involves as a provider is, transitioning care from a diagnostic and treatment modality to a supportive modality, and a modality focused on quality of life and on easing psychological burden and stress at the end of life. A lot of the care at this point becomes around chronic condition management and about considerations for how to help manage end of life. There's other things to think about in addition to IPF, which comes down to the secondary manifestations that are a result of A, pulmonary vascular disease, or B, the side effects of the therapy itself. And another consideration as the patient progresses in their disease course is what is the unmeasured financial and time toxicity related to receiving medical care in patients who have significant progression of their disease despite initial management. And we just want to highlight that IPF care requires multidisciplinary care beyond just making the diagnosis, which is something we already highlighted initially. So, the medical management, while it initially involves multidisciplinary discussion of the initial diagnostics, it also involving pulmonary hypertension or cardiology colleagues for the consideration of right heart cath and pulmonary vasodilators. And then often involves, for patients who progress, the involvement of palliative care physicians and psychologists to help manage symptom-based therapy for cough, air hunger, and psychological distress. The number of providers that often assist in the care of a patient with IPF can be many, from, again, pulmonary rehab providers, palliative care physicians, pulmonary hypertension teams, ILD pharmacists, lung transplant teams. And then again, in multidisciplinary team members at an ILD center often involve not just pulmonologists, but radiologists and rehab medicine teams, respiratory therapists, and palliative care physicians. Well, thanks again for the opportunity to present these topics on progressive pulmonary fibrosis as it pertains to SSc-ILD and IPF. Dr. Volkman and myself, thank you for your attention, and we're happy to present our slides to you today.